Good afternoon, everyone. So for the session 2 of non-metastatic prostate cancer, we saw that first there was a discussion on Protect Trial. So once we have a case of non-metastatic prostate cancer in our clinic, first the deciding factor would be their life expectancy. If life expectancy is 10 years, as it was alluded, observation or watchful waiting is one of the options. Life expectancy more than 10 years is where a lot of options open up, as was discussed, of active surveillance, radical prostatectomy, or radiation therapy. The only problem is defining a protocol for active surveillance, which I think is still a work under progress. And to decide on the active surveillance versus active treatment of RP or RT, it all comes down to how we actually risk stratify the patient. So if the risk stratification is wrong, then the whole gamut is lost. And how we risk stratify is the point to be noted with evolving of MPMRI and PSMA PET-CT, with a lot of discussion happening in that space. I think risk stratification is going to be the key before we decide on active surveillance versus active treatment. And next, once we decide on going for an active treatment, there's a never-ending debate of RP versus RT, which we saw with our panelists fiercely discussing, uro-oncologists going for RP and radiation oncologists pitching for RT. I think it all comes down to the center's experience. It all comes down to MDT. As a team, what you can best offer for that patient should be decided upon. And next, coming to functional outcomes after an RP, we've seen discussion. It all comes down to the man, not the machine, not the technique. And as we've seen, the urinary incontinence was more with RP, whereas the sexual function, there was no much difference. But the moment 10-year follow-up comes, it almost boils down with equal results on both sides. And then coming to the oncological outcome, a 15-year data follow-up was seen, and quite clear that with the higher DMECO risk stratification, the outcome goes poor. So it all comes down to how we really stratify these patients for the surgery. And then we've seen what if there's an unconventional histology. This paper clear-cut says that both the functional outcome and the oncological outcome with unconventional histology is poor. And as the panelists rightly discussed, in these cases, the baseline PSA level itself is low. So do the standard definition of BCR really fits for these unconventional histology? Should an upfront adjuvant therapy should be the way forward? Has to be looked upon. Thank you.